Thank you very much, Deborah, and thank you to the Northwest Leadership Academy for inviting me to speak here. It feels like an immense privilege to be in such an amazing building. It's just breathtaking, and it feels a real privilege to be able to speak here, and even more of a privilege to have some of your time this afternoon to talk about the issues that we're all grappling with at the minute. And I was reflecting on what Deborah was saying and thinking, 2 nights ago, I was talking with a very dear friend of mine who lost her partner recently. I was at college with her back in 1834, and she said to me, her partner died 2 weeks ago, and she said, "Thank God for the NHS." Just the care, the compassion, the presence by people who are in effect strangers in caring for her partner during the course of his terminal illness. And I was reflecting yesterday also, listening to what was going on in Parliament about the fact that we've got 1.4 million people who at some stage in their lives made a decision to dedicate their work lives to helping their fellow human beings who may be in pain or who need care or who need support. And so the challenge, it seems to me, for us as leaders, recognizing that context, is how can we create the conditions, the circumstances, where all of these people who want to dedicate their lives to helping other people are enabled to do so in the most effective way. And I think that's what leadership in health services means. So that's what I would like to talk about today. I should just check, are you all in the right meeting? Have you come to the... It is a health service meeting you've come for. Good. So I think the other thing that feels really important to me about the health service is it is a service or an industry that is focused on evidence-based practice. We want to make sure that we're using scientific evidence to make decisions about how we provide healthcare for people. That seems absolutely right. We don't want to use astrology in healthcare or whatever. I also think the implication of that is that we need to make sure that our approach to leadership and organization development is also evidence-based. There is so much out there written by people who don't come from a research background, who base their approaches to leadership and organization development on their good ideas. But I think that it really is essential that we create cultures of evidence-based practice so that everything we do in healthcare is about, it has an evidence base to it, so that the culture has an integrity to it. And so in talking with you today and exploring how we can create the conditions through leadership for producing cultures that deliver high quality compassionate care, I want to draw on research evidence. And there are three main sources I'll draw on. The first is a 6-university collaboration also with the National Association for Patient Participation that we completed a few months ago, focused on examining the extent to which there are cultures of high quality care across the NHS in England. And that study involved an enormous amount of research, 650 hours of ethnographic observation, members of the research team sitting in wards, sitting in A&E units, sitting in primary care reception areas, watching what was going on. What's the way people do things around here? There were many interviews with key stakeholders. We analysed board meeting minutes for 70 trusts over an 18-month period, 80,000 pages of the most exhilarating reading you can imagine. But a real source of insight into what was going on. What were they talking about during these meetings? We also had survey responses from patients. We completed the biggest ever study of clinical teams, 650 clinical teams that we surveyed across the NHS, and we also looked at the functioning of boards. And you can see it was spread across all of the sectors of the health service. And we concluded from that, I should mention that the other 2 sources of data I want to draw from are the National Staff Survey, which is a treasure trove of knowledge about the NHS. It's just amazing what we can derive in terms of knowledge about cultures from that. And the third is a 30-year program of research on healthcare teams in the National Health Service. And what came out of all of that work was, I guess, 6 important messages about how we can create cultures that deliver high-quality, compassionate care. And there are 6 areas that are outlined here, and I want to talk about each in turn, and to explore the extent to which we are creating the conditions already for high-quality care, but also to talk about what some of the challenges are, the gaps in our practice that we need to close if we're to fulfill the vocational ambitions and aspirations of those 1.4 million people who desperately want to provide high-quality care. So the first is about having an inspirational vision and a set of values focused on high-quality care. And vision, it kind of always sounds like, well, it's just a bunch of words that you put on the website or in the strategy document. But it is important because what vision is doing is saying to everybody in the organization, this is what we are about. This is what this community, this organization, this trust, that is just another human community. This is what we are about. This is what we stand for. This is what we're pursuing. It provides direction. It gives people pride. It gives people a sense of where they fit in within the organization. And if you look at organizational missions like the NHS England mission, they are inspiring, and they're meant to be inspiring. They're meant to motivate people. They're meant to make people feel good about what it is they're doing, but they're meant to give direction overall. And every trust that we went into during the course of our work had a vision, and they were more or less inspiring, and they were pretty much all of them emphasizing high quality care in the NHS. So that's really good, really is a source of comfort. However, when we looked at the board meeting minutes, what we found was that what boards were often talking about was not high quality care. In fact, in many of the board meetings, the quality of care was not an agenda item. It was barely discussed. In fewer than 18% of cases were patient complaints ever discussed. And a lot of time was spent discussing other issues. Patient experience was almost never discussed. So when we have visions, the purpose of a vision is that it should tell us, in a sense, what our DNA is. But actually what we see very often is that boards are discussing other issues like productivity, cost effectiveness, meeting the requirements of regulators, rather than focusing on the quality of care as the priority. Those things are important, of course, because that's how you run organizations effectively. But actually, if they become more important than delivering high quality, compassionate care for the board, guess what? It trickles down through the organization. So what we found was that in boards where high-quality care didn't seem to be a priority, as evidenced by the minutes and what board members said about their objectives, staff members in the National Staff Survey said they were not able to deliver the quality of care that they wanted to. They didn't feel supported to deliver the quality of care that they needed to. So how leaders, the kind of leadership we have, and the way leaders behave has an impact on the whole organization. So when we have visions, we have to live them. And that applies to people at board level, right down through the organization to leadership at the frontline level. That actually what staff see is that high quality care is the #1 priority. And that is evidenced to me by what my leaders are paying attention to, what they're monitoring, what they're rewarding, what they're talking about. Make sense? So #1 is, visions are great. We need to get them right, but we need to live, our leadership needs to live the vision. It needs to embody the vision, not merely use it as a set of words to satisfy the regulator. And it's also about recognizing that what vision communicates is the values of the organization. And when, Deborah used the word culture, and I've come to believe in my work life that actually the real action in understanding organizations and changing organizations is culture. Culture is the way we do things around here. It's the difference, we sitting in trusts, in one acute we went into, there was an elderly lady waiting in A&E for about 4 hours by herself. She'd been seen initially, and then she was left to sit in a wheelchair. And one of our team members was sat close watching, and the lady fell asleep. And then after about 4 hours, a porter came walking up to the wheelchair, clearly having been told where she needed now to be taken, and he pushed the wheelchair off, and she was frightened and clearly shocked, and was taken up to a ward. And as they walked into the ward, somebody came out from behind the desk, and this lady, her face broke into a smile of greeting, and the person who came from behind the desk shouted at the porter, "Who said you could bring her up here?" And the lady's face fell because it was clear she thought she was being shouted at, and then she started to cry. It's the way we do things around here. Versus a situation that we observed where a healthcare assistant spent nearly an hour after her shift had ended stroking the hair of an elderly lady who was in distress to comfort her. The way we do things around here, that's what culture is. And what culture does is communicates our values. It embodies our values, actually, as an organization. Is compassion what we are about? Do we behave compassionately? So when we say what our values are, do we then live them? And the sorts of values, I guess, that we'd want to see within the NHS are high quality safe care, the number one top priority. Compassion, transparency, empowerment of the people who are delivering the care, cooperation, people helping each other in order to deliver integrated, seamless care to patients. And the most important influence on values, and values are culture, is leadership. That's the most important influence. So how leaders behave, or how we as a leadership community behave, creates in a very powerful way the cultures. It makes the difference between people treating patients as tasks versus treating patients as people. The second then is, and I think this is important to understand about leadership, that we all may have views about the extent to which leadership should be empowering, democratic, hierarchical, directive, or whatever. It's clear that we need to have both some level of direction and some level of empowerment. If we make a mistake in health services, it's very clear it is too much hierarchical, top-down command and control, and that there is a real need to shift the style of management and leadership that we have. But what we do need is for people to be clear about what it is they're required to do. So we need to translate vision and values into clear objectives for the whole organization. So we need to make sure that every board and an executive team has clear objectives. And most of them don't. If you ask them what their objectives are, they say, well, we've got the organization's objectives articulated. We're clear about what the organization needs to do. Yeah, but what are you as a team? What are your objectives? How are you going to enable this organization to achieve its purpose? So the top team needs clear objectives. Every directorate, every department, every team, every individual also needs clear objectives, aligned with and derived from the vision and values. That makes sense? 6 or 7 will do. So, I've been visiting trusts recently, and you find that where the top team does have some objectives, there are 35 or 40 or whatever. What we saw in the NHS was what we came to call priority thickets. Everywhere we went within NHS organisations, there were priorities. And there were so many priorities that nobody knew what the real priorities were. So they began with the regulators and the Department of Health, and they trickle down to boards, and boards trickle them down. By the time they get to the front line, people are just overwhelmed with all of these priorities. And it means people are not clear about what it is they're required to do. What's really important? 6 or 7. They need to be really clear, and they need to be challenging objectives. We know that from research on goal setting over the last 100 years, that people perform to a much higher level when they have challenging objectives. There is an almost linear relationship between how challenging objectives are and how highly people perform. I heard somebody say recently, at a very senior level in the NHS, why are we giving people increments when they're not achieving their objectives? This seems to me a really misguided idea. If we say to people, you only get rewarded when you achieve your objectives, it is a recipe for them setting the least challenging objectives they possibly can. What we should be doing is enabling people to be successful and rewarding and recognizing progress towards achieving objectives, not have you achieved them or haven't you. So challenging clear objectives in a limited number. I worked with David Nicholson's team earlier this year. They got it down to 5 objectives. So if his team can get it down to 5, then I think in every organisation we should be able to get it down to a limited number. They did try, by the way, to add a 6th, which contained 10 more objectives, but we had a discussion about that. Make sense? Third is the real importance of people management. And actually, I want to sum up what I want to say here in basically one sentence. If we want staff to treat patients with respect and care and dignity and compassion, we have to treat staff with respect and care and dignity and compassion. And that is an evidence-based statement, and it's so fundamental and so important that if we don't understand it and embody it, then it has real implications. So if a manager is a bully, or is very directive and very controlling and very harsh and very brisk, that affects people's behavior within the organization towards patients. It also affects the way people manage 2 or 3 levels down, because people unconsciously model their leadership behaviors on the people who are above them. So if we want to create cultures of high quality, compassionate care, we have to be compassionate. And the data from the National Staff Survey, as I said, is a treasure trove, and we've been able to link it to CQC, quality of care data, use of resources, mortality and patient satisfaction, and so on. And what we see is that patient satisfaction is highest in organizations that have clear goals at every level. Patient satisfaction is higher where staff feel satisfied and committed. Patient satisfaction is higher where staff report that their immediate managers are supportive and positive in the way that they deal with them. And generally what we see is where staff are positive, it has an impact on patients. And that's because, what we create in organizations and cultures is a kind of emotional contagion. If people are being warm and pleasant and supportive and enabling to each other, and there's a sense of optimism and cohesiveness and support, it communicates itself to patients, and people behave as a community in a compassionate way. The evidence is there to support all of this really clearly. The converse is also true. When staff report high work pressure, patients say there are too few nurses and they're not treated with the respect and the care and the dignity that they want. What I think that the Secretary of State should be paying attention to, much, much more than anything else, is not the 0.1% or 0.1% of people who would willfully neglect the people that they're asked to care for. It is the fact that after teachers and welfare professionals, nurses are the most stressed group in the UK working population. That's the political issue to address. That's the issue that we need to focus on. Because if we want to create cultures that are compassionate, then we need staff who are able to be compassionate. But if staff are really highly stressed, it's very difficult for them to find the emotional resources to respond effectively to the people that they're asked to care for. I find it a shocking statistic, and it's not changed in the last 15 years. We have not done enough to address the issue. And the number one factor predicting stress amongst nursing staff, and indeed staff in the NHS generally, is workload. That people feel overloaded by work, and that we need, as a leadership community, to address those issues of workload. What is compassion? Compassion, we can think of as having three components. Paying attention to the other who is in pain. Compassion is noticing the other person, noticing what they're feeling, noticing that that elderly patient can't reach the water. And the second component is empathy, is having an empathic response, is, if we see somebody in pain, that we feel for them, we feel pain for them. And then the third is the decision to take intelligent action to help them. So noticing, paying attention, empathy, and taking intelligent action. If we're really stressed, we are less able to pay attention, we are less able to have an empathic response, and we're less able to think clearly, to take an intelligent action to help the other. So if we're going to create compassionate communities, we need to deal with this issue of compassion towards staff. And where does compassion begin? It begins with me. It begins with each of you in this room. As a leader, to create compassion, you first of all have to be compassionate to yourself. You have to pay attention to yourself, how you're feeling as a human being, as a leader, have an empathic response, and take intelligent action. Because leaders have to embody the values, and compassion is first. We can only be really compassionate if we've been sufficiently compassionate with ourselves. Make sense? Good HRM practices, we discovered, were associated with low and decreasing levels of patient mortality. It's the third study that we've done looking at the links between people management practices and patient mortality. And what we've been able to show is that as good HRM practices spread out to touch more members of staff, so mortality subsequently declines in trusts. We published a paper in 2002 showing this link, another in 2006, and this is an even bigger data set with a different methodology demonstrating this effect again. But it's not about just importing HR practices from some private sector organization. Increasingly, we know that good HRM practices means human resource management practices that reinforce the values of the organization. So selection and recruitment practices that focus on those values about compassion and the primacy of high quality care. Training and appraisals that focus on those issues as well. So it's making sure that our HR practices are really aligned around the values of the organization, not simply imitating the HR practices of KPMG or Deloitte Touche or wherever. It's HR practices for our health service that we need to be developing. There's work to be done there. And it's about the quality of them as well. We know that, there's now something like around 76-80% of people report having an appraisal in the NHS, up from about 62% back in 2003. But the percentage reporting that the appraisal has been really useful has barely shifted in that period. So it's about having HR practices that work, not kind of tick box exercises. And then the fourth area that I want to mention is the importance of staff engagement. What really has stunned us in analysing the data from the staff survey over the last 10 years is just how important staff engagement is as a predictor of a range of outcomes: patient mortality, staff absenteeism, patient satisfaction, CQC indicators of quality of care, and so on. And we know some of the factors that predict staff engagement. And but I kind of think that the challenge that I think we face is, that everybody faces, is how can we increase the level of staff engagement within our organisation? How do we go about doing that? It's worth noting that there are three elements to the measure of staff engagement in the National Staff Survey. So one is advocacy, the extent to which people would recommend their organisation, you know what I mean, their friends and family test. The second is intrinsic job engagement, how excited you are by your job, involved in your job. And the third is proactivity and involvement in decision making, the extent to which staff feel committed to improving things within their organisation, to being involved in decision making, to being actively involved in improving the organisation, in giving feedback to each other, in trying to make the kind of difference, in being empowered that you talked about, Deborah. So how can we create the conditions for that? And I want to say that I think the most important way we can create the conditions for staff engagement is really very simple. It's so fundamental and so profound that we just completely forget it. What we've come to understand in the last 15 years in psychology is, and it's created a tectonic shift in our understanding, is just how important emotion is in human behavior. We kind of think of ourselves as being the intelligent animal. We're the ones with the big brains. My daughter's doing anthropology at the moment in university, and she keeps telling me, we're just another primate, Dad. Look at you. We think we are really different. Actually, what really determines our behavior is our emotions, primarily. What we think is far less powerful in influencing our behavior. And positive emotions are really powerful, and negative emotions are really powerful. And the ratio of positive to negative emotions is hugely important. If you take the top 5% of the population in terms of the level of positive emotion and the bottom 5%, there is on average a 10-year longevity gap between them. So that highly positive people live 10 years longer. If you induce positive emotion in a 3-year-old, she will produce more creative paintings and play more altruistically and cooperatively with other 3-year-olds. And the same is true for 83-year-olds. If you induce positive emotion in doctors, they make better, more accurate diagnoses and decisions on treatment. If you have positive leaders of teams in healthcare, those teams are more cooperative, there's less conflict, and they provide better service to patients, according to patients. You can predict marital outcome on the basis of a 20-minute observation of interactions between couples by observing the ratio of positive to negative interactions between them. The minimum ratio is 5 to 1. But if you start counting, you're lost. Negative emotions have a huge effect on us. If you induce negative emotion in people, their thinking narrows, they become less creative, they are less able to be empathic towards others, they are less able to feel compassion, they display less attentional broadening, they display less empathy, and they don't think so intelligently. If you shout at a shop assistant who's upset you for some reason, she's much less likely to be able to solve your problem for you. Research evidence demonstrating exactly that. The ratio of positive to negative emotions is really important in our behavior. The more negative emotion there is chronically, the more likely people are to get stressed. The health service, think about this, reflect on it, is a context within which there is a good deal of negative emotion already. There is pain. There is a lot of fear. People feel out of control. And when we are working in that context, we experience those negative emotions because of empathy, because we are the animal that best of all can mirror and experience the emotions of others. We pick up everyone's emotions. There is enough negativity within healthcare already. We have to work to create a really positive emotional environment for staff to work in. Remember what I said about nurses being the most stressed group after teachers and welfare professionals in the NHS. If we want to create engagement, we need to create positive climates for people within the NHS to work with. That means leadership that is optimistic and positive and celebratory. Events like today are fantastic for doing that. Optimism, celebration, a sense of efficacy, cohesiveness, supportiveness. When I left university, I went and worked in a coal mine for a year. You're all too young to know what coal mines are, but we used to have them in this country. And what really struck, by the way, interesting thing about coal mines is productivity was really important in coal mines because that determined your bonus at the end of every week. But there was something far more important, and that was each other's safety. And that was really clear to me. You can have productivity as a value and still have something as a more important value, like quality or like safety. Anyway, in the coal mines, what was clear, everyone looked out for each other. Everyone supported each other. You had to, because it's such a hostile environment. And there was so much humor. And it was a way of creating, in one sense, a positive environment for people to work effectively in. So we need to create positive environments. And negativity is necessary. We need to be afraid at times. We need to be anxious. And there are times when we need to be angry, but not very often. It also... by the way, what I'm not suggesting is that you have to come into work as a sort of happy-clappy individual on a Monday morning like this in terms of leadership. Can you read that at the back? Yeah. So actually what I mean from a leadership perspective, creating a positive environment is about being real. It's about being authentic. It's about being open as an individual, about being open and being transparent and being honest. It's about being curious, about wanting to learn, about how can we more effectively create the kind of cultures that we want. It's about being kind to people that we lead and to the whole community. Human communities are founded on kindness. My 82-year-old next-door neighbour takes my bin in when the bin lorries have been, when I'm not at home. It's about being kind, and it's about being appreciative. So being real, being open, being curious, being kind, and being appreciative, I believe, produces the conditions of positivity that we need our leadership community to produce so that we create more positive environments so that people can give of their best in healthcare. And it's also about dealing with some of the negatives as well. So it's about dealing with disruptive behavior. So all that I've said so far you could say, well, I can buy into that. But it also means that for those individuals who are abusive in their behavior or disruptive or whatever, we deal with it quickly, effectively. We coach them. We are immediate in our feedback to them. I saw how you behaved with that member of staff. And if that had been me, I would have felt really put down and disrespected and upset. I'm not sure that's helpful. What do you think about it? Actually, I know it's not helpful. What do you think about it? So it's dealing with disruptive behavior. Every acute trust I go into, there are at least 2 consultants who aren't on speaking terms. Somebody said only 2. And we kind of giggle about it in the health sector. I don't know any other sector where that would be tolerated. In my work experience, in many parts of industry, I don't know any other sector where that's tolerated. But it is giggled about here. It is unacceptable. It is unprofessional. And we should be decisive as a leadership community in dealing with those behaviours, just as we should be decisive about dealing with poor performance, because in the end, these things affect patient care. It's not just that these two individuals are difficult, they don't get on. It has a negative effect on patient care. It has a negative effect on the community. It has a negative effect on the culture. And if you allow it to continue, it will be corrosive. When a junior doctor comes in to the organisation and sees senior consultants behaving in that way, he or she thinks, maybe subconsciously, that's the way we do things around here. That's what consultants do. And it will affect their behaviour. I said that leadership is the most important influence on culture. The second most important influence on culture is socialisation. What people learn when they first come into the organisation, how they see people behaving. And if they see bad and abusive behaviours, then the message gets through. The other bit about, that takes courage. All of this takes courage. But that's what leadership is about. And the other aspect that's important to recognise is that people do have negative experiences at work, particularly in health service. If you've been caring, for example, for a sick child, which we see particularly in the children's hospitals, and that child dies after a long illness, the staff are profoundly affected. The role of leaders is to help people deal with those emotions and turn them somehow into positives, to understand that the role they played in helping that transition to death and the bereavement process be managed effectively by the family was a beautiful thing, was an amazing thing, was a spiritual thing. Our role as leaders is to help staff process negative emotions. There is too little reflection after negative events. Schwartz rounds, great idea. After event reviews, what can we learn from this? Let's give people a chance to express their negative emotions, because what we know is when you do that, when there's that kind of process, people leave work more positive than if the negative event had never happened. And they think more creatively as a consequence. So really important issues to do with negative emotions. And there are all sorts of other factors that we know enable staff engagement, but I want to mention one in particular, and that's about a climate of fairness. My great colleague, Jeremy Dawson, who I've worked with over the last 15 years, analysing the data from that we've been collecting in the health service, has just finished some analysis looking at what predicts well-being amongst NHS staff. And the most important is that they feel that they are treated fairly, that there isn't discrimination at work, that there is equality. Fairness is a really important aspect of culture. People need to feel that they're treated fairly. We know unfair things happen, but when people at work believe that their organisation is fundamentally fair, when unfair things happen, they have a more constructive response and a less destructive response. So the role of leadership is to create communities where there is a sense of fairness. It's what human communities are built on trust. And then team working. Well, it kind of feels really pretty fundamental, and it goes without saying that team working is important in healthcare. We know there's a link between team working and patient satisfaction. But we also know from the National Staff Survey that though 91% of people say they work in a team, there's probably only about 40% who work in what we would say are real teams, and about 50% work in pseudo teams. And that I'm not going to dwell on the data, but because it's all on the Department of Health website. In primary care, the more people who work in pseudo teams, the more errors, near misses, the more violence against staff, the more bullying, the more harassment. The more people who work in real teams, the less of those things. In the acute sector, the more people work in real teams, the lower the levels of errors, stress, injury, bullying, violence, abuse, and even mortality. And it's as simple as, does the team have clear objectives? Do people work closely together as a team? Do they meet regularly to review their performance and how it can be improved? And what we see continually is that teams are not meeting together They often don't know what their objectives are. They don't even, the survey of 650 clinical teams I described to you, they don't even know who the other members of their teams are. So we ask the team leader, who are the team members? And they say, well, there are these 5 people. And then we ask these 5 people who their team members are. And we typically get 5 different accounts of who's in the team. So there's just the kind of basics of teamwork that need to be put in place. We also know that when people work in real teams, they're much less likely to be stressed. I've talked already about the importance of stress in the NHS. I kind of want to get across the idea. Stress is like a word, it may sound like a sort of self-indulgent, neurotic, middle-class anxiety. Stress kills. Chronic stress kills people. It is a major cause of myocardial infarction. It's a major cause of all sorts of other illnesses and failures to recover. It is a really important issue that we need to deal with this. Using the National Staff Survey data, we found that if there were 5% more staff working in a team in an acute hospital, this would be associated with a 3.3% drop in mortality if this was a causal relationship, which is the equivalent of about 40 deaths per year. And we took account of all sorts of other factors like size of organisation, NHS facilities per 100,000 population, number of doctors per 100 beds, and so on and so on. What we found was that 5% more people working in real teams in an acute hospital would be associated with a 3.3% drop in mortality, which is the equivalent to about 40 deaths a year. 40 deaths is 40 deaths. You may say, well, that's not very much. But if, let's say, there are 150 hospitals, then we're talking about 6,000 deaths if this is a causal relationship. Let's say that 5% could be increased to 25%. So we'd have 65% of people working in real teams in the NHS. Then we're starting to talk about 30,000 deaths a year. The links are so strong that they provide compelling evidence that this is an area we, as a leadership community, really should be working on. And it's just as simply as saying, let's make sure we are clear about what teams we need, who needs to be in them, giving them clear objectives and making sure that they meet regularly and review their performance and find ways of improving it. And one of those objectives should always be, those 6 or 7 objectives, one of them should always be improving the effectiveness with which we work with other teams in the organisation to deliver patient care. Every NHS team should have that as one of its objectives. I'm going to flick through the next slide. And I want to finish what I want to say about team working by talking about, I guess, cultures of frenetic, desperate activity. What we saw in the NHS during the last 4 years of our work, what I've seen over many years of working in the NHS, is everyone is so busy. The level of activity is just unbelievable. It's frantic, it's stressful, it's panicky in some cases. We've been conducting a program of research over the last 20 years on what we've called reflexivity, which is the extent to which teams take time out on a regular basis to review what it is they're trying to achieve and how they're going about it. And our research has convincingly demonstrated that teams that do that get much more work done and are much more innovative in developing new and improved ways of delivering patient care. Indeed, in the top management journal in the world this week, there is a paper showing that surgical teams that adopt this reflexive approach are much more effective, much more innovative in achieving patient outcomes and surgical outcomes. So we need to be saying to teams as a leadership community, not wouldn't it be good if, we need to be saying it is good practice to take time out on a regular basis and reflect on what we're trying to achieve and how that we're going about it in order that we can improve and be more effective. It's about learning to work smarter and more effectively. Actually, the other thing I'd say is that as leaders, we need to do the same. We need to practice mindfulness as leaders. Take up yoga, do meditation. But, as leaders, we embody the culture. If we're frantic, if we're desperate, if we're overloaded, if we're not compassionate with ourselves, it affects the whole culture. Make sense? And these are the things that I think in terms of leadership we need to have within teams. We've talked about most of these. We need to have regular and positive team meetings. Team meetings should be occasions for celebration and occasions for appreciation and occasions for positivity and optimism. Of course, dealing with the difficult stuff. And it's not, we've talked about conflicts already. Interpersonal conflicts are immensely damaging in our cultures. They corrode healthcare cultures. Dominant leaders don't listen, that we know. So people don't have a voice, they're not empowered to make change. And it's about leading into team cooperation. That our role as leaders is to make sure that we're promoting inter-team, interdepartmental cooperation and focusing on loyalty to the organization as a whole. And I want to finish on leadership, which in a sense I've been talking about all the way through. I've mentioned pretty much all of these. I want to pick out just a couple. The importance of seeking and acting on high-quality intelligence to inform our practice within organizations. We saw so much data being gathered within the NHS. In one of the wards we were on, there were 200 different forms for staff to fill in. They barely came out from behind the desks. So there's a role of and interestingly, with the boards, we saw two patterns, what we called comfort seeking and problem sensing. Some boards were out there seeking comfort from the organization. And when they were told bad news, they called it whinging. Other boards we saw using every possible source of information they could to discover what they didn't know about their organization and the quality of care that was being produced. Leadership is about seeking and acting on high-quality intelligence. Case studies of patients' experience. You've been into this, into the hospital or the primary care team. Tell me about the journey. I've picked on you at random, We don't need to just concentrate on patients with complaints. Let's hear case studies of the whole journey so we can find out what went wrong, what went right at different stages, that tell us what we don't know, so that we're going through a discovery process continually as leaders. Giving helpful feedback and celebrating good performance. What a great occasion this is. But we should be celebrating good performance and giving positive feedback as leaders every day, every hour, if we are leading effectively, encouraging, coaching performance. And I want to finish by saying I think that what we need to do is to start thinking about how every organization can develop a leadership strategy. We saw a real absence of leadership strategies, and it's this word leadership. It's not about leaders, it's about leadership. What's our strategy? What leadership do we want over the coming 5 years? What sorts of people with what sorts of skills? How are we going to engage clinicians? At what levels? And what sorts of capabilities do we want? And above all, how are we going to ensure that that leadership community works together to deliver the culture that we want and is embodying the values that we've talked about here today? So at the King's Fund, where I now work 3 days a week, I'm delighted to say, we are developing templates of leadership strategies to help trusts ensure that they are planning their strategies ahead of time and creating the leadership that they need for their organizations, because leadership is what creates culture. And it's about understanding the values that we want to build organizational communities that really work. Human communities are founded on all sorts of values, but there are 6 that are core across cultures and across the world. We need our leadership communities to embody wisdom, wanting to learn in order to make a real difference. One of the medical directors in one of the trusts we work with now goes out regularly to the nuclear industry to learn about how they manage risk and safety. Wisdom. He wants to gather knowledge and evidence, not in a sponge-like way. And wisdom is kind of really important in a community, so that we are gathering knowledge which will really help us to create the conditions to deliver that high-quality care. And second is the importance of courage. The courage to have the leadership community has courage within it, the courage to have a vision, the courage to persist, to persevere, to keep going, to bring about the kind of culture that we want, the courage to stand up for what we believe in the organization, against sometimes the politicians and the regulators. The courage to be enthusiastic and zestful. The courage to deal with consultants who behave rudely to other people, and any member of staff who behaves rudely, and to deal with it quickly and decisively. Our leadership communities also need to have a strong sense of justice. I've talked about this already in terms of fairness and equality and openness and transparency. People only engage in organizations if they feel trust. So we need to create just communities. And we need to have our leadership community needs to embody humanity. If we haven't got kindness and humanity at the core of health service cultures, we are in deep trouble. My friend Jane said, thank God for the NHS, because of the humanity that was shown. And the fifth value that's important in any human community is prudence, caution, self-regulation. We have so many leaders who are overburdening the people they work with their enthusiastic ideas. Let's try this, let's do this, let's put this initiative in place. Initiative overload we saw within NHS organizations that pour down upon people at the front line. Prudence, caution. And part of prudence is humility. You know, we're learning that leadership, great leadership is humble leadership. Leadership that doesn't say, I'm right, you're wrong. Leadership that says, my role is to enable you and to learn from you and to empower you so we can make the changes we need to within this organization. And leadership is also about, do you remember I said earlier, not getting angry too often when that email comes in and your face flushes and you're sat there at 11:30 at night typing out the response with hate-filled fingers bashing the keyboard. The prudence to say, I'll wait before I send this. Or better still, I'll go and see that person face to face and talk it through. That's leadership. I have to say, in my career, the worst mistakes I've made as a leader are when I've been angry. And I've let anger dictate my behaviors. And I kind of now think, whenever I feel angry, why am I angry? What's this about? Let me be really, really careful at this point. This is a perilous place to be. Prudence. And the last one is wisdom and spirituality. That, you know, what we've talked about, what Deborah talked about in terms of, you know, your experience and what my experience is of healthcare organizations, is they are places of wonder and spirituality. This sector is a sector where 1.4 million people have dedicated their lives to helping their fellow human beings. The peak experiences of my life were in NHS organizations, seeing my children born and seeing, you know, them being cared for by people who were complete strangers in a way. And I've asked midwives, do you ever get kind of just habituated to delivering babies? And everyone has always said, no, it's always a miracle. It's always amazing. And I've watched people really dear to me die in health service organizations, being cared for with the most incredible compassion. These are amazing organizations. If we lose our awareness of that, if we get so locked up in the kind of technocratic leadership or, you know, management practices and forget that leadership is ultimately about values, then we've forgotten what connects leadership to the communities that they lead. It is values. It is the behaviors that we communicate our values through. So it's absolutely vital that from a leadership perspective, what we do is we create strategies, but we create strategies that are founded on these core human values, which exemplify the kind of cultures that we wish to create in order to go back to my point at the beginning, that we enable those 1.4 million people to fulfill the mission and the vision and the vocation that they have in their lives. It is a miraculous one. I'm so grateful for the privilege of talking to you this afternoon. It's been a real honor. Thank you. Thank you very much.